Welcome back after our short break. We are at the bottom of page 10. I think we are on line 18.
I look back up. Again, for the record, Jen Carvey from the Office of Legislative Counsel. We are in section 5 of S-126. We're looking at the hospital budget review statutes, and in this case, the board's. So in conjunction with budget reviews, we looked at the first new addition added by the Senate, which was that the board must consider the statewide healthcare delivery plan once established, including the total cost of care targets, and consult with the Agency of Human Services to ensure compliance with federal requirements regarding Medicare and Medicaid. Existing law requires the board to consider the Health Resource Allocation Plan, HRAP, consider the expenditure analysis for the previous year and the proposed expenditure analysis for the year under review, and consider any reports from professional review organizations. The new subdivision 6 would be for a hospital that operates within a hospital network. Review the hospital network's financial operations as they relate to the budget of the individual hospital.
Can I stop you briefly?
Yes.
Number 2 and number 3. Whole time we're talking about this statewide healthcare delivery plan, I had up on my computer the Health Resource Allocation Plan. I'm still not quite sure where they differ. And now we're asking them to consider both the statewide healthcare delivery plan and the Health Resource Allocation Plan. Should we be combining these two? What is the difference between them? And are we now setting the board up for failure of, do I listen to, oh, it's not even a very good acronym, Statewide Healthcare Delivery Plan or HRAP?
So the HRAP identifies how health needs, goods, services, and resources are allocated. The statewide healthcare delivery plan builds on the HRAP and other sources and information to determine how to, plan for delivering healthcare in Vermont. I think if you want to combine them, you can combine them. If you want to keep them separate, if you want to, it's really up to the committee to decide.
Where did you find HRAP? They took it off their website.
No, there's a section in statute.
Statute?
Yes. Established.
I went to the agreement.
It's section 9405.
Okay.
Section 9405.
You want me to pull up that statute? Is that helpful to look at?
It is actually, it would be. I'm just wondering if instead of creating a whole new start from square one, maybe when we get to section 8, which I know we're not on section 8 yet, and I don't even want to bring up section 8 yet, but maybe we should just be amending 9405.
So under existing law in Title 18 in 18 VSA 9405, there are two plans. There's a state health improvement plan that the Secretary of Human Services adopts, setting forth the health goals and values of the state. And then there is the Health Resource Allocation Plan that the Green Mountain Care Board, in consultation with the Secretary of Human Services or designee, must publish on its website. And that identifies Vermont's critical health needs, goods, services, and resources, which are used to inform the board's regulatory processes, cost containment, and statewide quality of care efforts, healthcare payment and delivery system reform initiatives, and any allocation of health resources within the state. Talks about identifying Vermont residents' needs for healthcare services, programs, and facilities, the resources available and the additional resources that would be required to realistically meet those needs and make access to those services, programs, and facilities affordable for consumers, and the priorities for addressing those needs on a statewide basis. It allows the board to expand the plan to include resources, needs, and priorities related to the social determinants of health. Requires the plan to be revised periodically, but not less frequently than once every 4 years. It directs the board to consider certain things in developing a plan, consider the Act 48 principles, as well as the purposes enumerated at the beginning of this chapter and the beginning of the chapter on certificate of need, to identify priorities using information from the State Health Improvement Plan, which is subsection A of the section, emergency medical services, resources and needs identified by the EMS Advisory Committee, the community health needs assessments required by section 9405A of this title, available healthcare workforce information, materials provided to the board through its other regulatory processes, including hospital budget review, oversight of ACOs, issuance and denial of certificates of need, and health insurance rate review, and the public input process set out in this section. Use existing data sources to identify and analyze the gaps between the supply of health resources and the health needs of Vermont residents, and to identify utilization trends to determine areas of underutilization and overutilization, and consider the cost impacts of fulfilling any gaps between the supply of health resources and the health needs of Vermont residents. Directs the board to convene its general advisory committee to provide recommendations to the board during the board's development of the plan. Requires the board to receive and consider public input on the plan at a minimum of 1 board meeting and 1 advisory committee meeting, and give interested persons an opportunity to submit their views orally and in writing. Requires the board to include reproductive health care services and gender affirming health care services in its plan analysis. And then there are definitions of health resources, or because a definition of health resources, what it does include and what it may also include.
Thank you. Thank
You're
you.
comprehensive.
It's sounds pretty comprehensive. Hopper.
How often does that emergency advisory board meet?
Really frequently, I think you worked on about them last year. The EMS Advisory Committee, and changed their scope of their role a bit, or their responsibilities a bit. I don't know specifically, I'm not sure it's specified how frequently they meet, but they do meet.
It's just sticking out to me because here we are asking them in their budget review process to number 2, consider the statewide health care delivery plan, and number 3, consider the health resource allocation plan. And what if those plans clash?
Or combined.
What if those plans were combined?
Because what I'm looking at is the difference between delivery and allocation. And that's different. And I think needs to be I need more help understanding how it addresses different regions of the healthcare delivery system.
Okay. Well, I'm just gonna think about that when we get to section 8.
Yeah.
But thank you.
And Representative McFawn, I looked up the EMS Advisory Committee statute. The committee must meet not less than quarterly and may be convened at any time by the chair for the request of 11 committee members.
That's-
At least 4 times a year.
Yeah.
All right.
Okay, sorry, moving on.
Back to 126. All right, so then we had this new addition of, for a hospital that operates within a hospital network, review the hospital network's financial operations as they relate to the budget of the individual hospital. So I'm thinking it may make sense, we have various bills, and including later in here where we talk about, where we give a definition of hospital network. And I'm just thinking it may make sense to have the definition in one place. Maybe at the beginning of this the entire chapter, and have it apply to the whole. Or it could even be in this subchapter. But move it from
Move it from where it is in section 6 and put it here.
Well, I'll move it to the beginning of this subchapter. It applies to both this section and section 6.
Yeah. So,
So that's more of a placement issue for me. All right. So review hospital network's financial break operations as they relate to the budget of an individual hospital. Number 7 is exclude revenue derived from primary care, mental health care, and substance use disorder treatment services when determining a hospital's net patient revenue and any total cost of care targets. You got some testimony on this.
Yeah.
This makes sense.
well, I have May. What do you got, Leslie?
Well, what I got was, let's say, consider revenue derived, not exclude. So the issue is exclude or include. Exclude or consider. Because why wouldn't we want hospitals, why wouldn't we want to know the revenue from primary care? Because we want that to increase.
Yeah. How about may consider?
Right, I think it may be the treatment of it as part of net patient revenue versus, ignoring it entirely. I don't think this says, don't look at the revenue. It just says exclude it when determining a hospital's net patient revenue and any total cost of care targets.
But why?
Still doesn't mean it's right.
Yeah.
But I think the rationale had been to allow those revenue from those services to grow without imposing the same limits on them that might be applied to other types of healthcare services, because those were the types to encourage. Again, doesn't mean this is the right.
Yeah.
Anyone have thoughts about this? I have some, but anyone else speak?
Just number 7.
Just number 7.
I'm trying to remember if there's specific.
Well, I don't think we agree, but I think it should be included. But I can see how we don't want to, undermine the hospital for doing primary care. So how do you do both?
Well, sorry, I'm looking around the room to see who's gonna veer at me.
Not a lot of people left to glare.
One of the things that hospitals keep coming in and they keep saying, we lose money on primary care. It's a loss leader.
Loss leader.
And yet, figure out why. I have a hard time. I'm looking over at Blue Cross, and I see some others left the room. I'm having a really hard time understanding why a primary care provider in a hospital setting might be reimbursed 2 to 3 times more than a provider in a non-hospital setting, and yet the non-hospital setting provider is able to stay in business and it's a loss leader for a hospital. And I think when you take out, what are the expenses? If you exclude revenue from primary care, mental health care, substance use disorder treatment, if you just exclude those, you're sort of saying, charge whatever you want, spend as much on expenditures for these things as you want, because it doesn't matter, it's not going to get included in your hospital budget review. And I think it needs to be, because I think somebody needs to be looking at how much is it costing you to deliver, mental health care, as opposed to, I'll use Brian as an example.
Whoa.
why is Brian able to deliver that care? And yet somehow excluding hospitals from having to include in their, how much their revenue they're deriving from it, and more importantly, what their expenses are. Hopper.
I don't know. I don't know what Brian, what his expenses are.
I could easily show you.
But yeah, I don't think you have much overhead. But it
What?
seems to me the hospital has.
We need to do a study on that.
That's maybe why they don't make any money.
I see Devin's hand too.
I
though.
see Devin's hand, but I'm gonna ask Brian to go ahead and sit.
Well, it's not.
I said I'm gonna get leering looks.
This is about the hospital, not private practitioners, but the reason that I would have that I have a problem with this, I wasn't necessarily wanting to remove it, but the reason I have a problem with excluding it is we have had a problem with certain unnamed hospital systems eating up the primary care practices, or that's probably a bad way to put it, but like, subsuming them, or that's another bad word, but I'm trying to think of like annexing them.
Maybe by choice.
Acquiring, and it also sounds pretty bad.
But it may be by choice.
Yeah, and maybe because it's the only way to stay solvent, right? Right, so that being said, if we're excluding that revenue, we're kind of missing a piece of the picture. I don't think it should necessarily be used in a bad way, but we need to understand the financing. And, Topper's comment about private practice and the overhead not being that high, it's actually not true. So yeah, it's not true. So
I don't know.
yeah, so we might want to consider, like, how do we get a better sense of the cost of doing business as a healthcare provider? Because there's a lot of costs people don't realize. And then as those costs go up, which they are, it's like this spiral. It's like those costs are going up, and then the cost of healthcare goes up, which then healthcare providers are paying too. And it's this vicious upward spiral of inflation. So, I mean, this just brings to mind how we don't fully understand the mechanics of the sector, the economic sector of healthcare. That was my comment.
I just want to be clear that this is not saying don't look at what it costs to deliver those services, don't exclude those. It doesn't say exclude those expenses. It says exclude that revenue when determining a hospital's net patient revenue, which is what they put the caps on, and any total cost of care target. So just exclude those from that calculation.
Just that one.
Sounds like
calculation.
supporting primary care in a way, right? That would be
Yes,
supporting
it is,
primary care.
right. I think
Yeah,
that
that
makes
the
sense.
idea is to
Is that
support
what you were gonna say?
investments and, spending on primary care, mental health care, and SUD treatment, by excluding it from caps.
Right, so.
That makes more
penalize
sense.
The hospitals for doing it.
Yeah.
Oh, I see you, Sarah. I'm just thinking for a sec. Sarah.
So, if you exclude this, from especially the total cost of care cap, that's how the Green Mountain Care Board is controlling overall spending on healthcare services in the state of Vermont. And those are used, so you're excluding from them their ability to oversee and control those. It's part of it, all costs.
Oh, Leslie.
So from my notes, it says, take away, exclude, but consider, which gives them more flexibility. So that was the word that I heard from their text.
I think that was
May
an
exclude.
advocate, was one who had,
No, I wrote Green Care Board, but I could have gotten it wrong easily. Just say don't exclude, but consider.
because I'm not sure what that would,
How that affects the,
right, what that means.
yeah.
I have May exclude.
Same idea.
Right, although then it throws off the whole, in conjunction with budget reviews, the board shall
Oh,
may consider.
sorry.
But I think it would be important for the committee to decide what your goal is with this. If you leave some version of this in, what is your goal?
I mean, if we're asking them to to think in alignment with the total cost of care targets, why would we exclude the revenue from the total cost of care? Because the total cost of care is the cost of care across the whole system.
Right, I think the two perspectives you're hearing are either you shouldn't exclude anything, you should be looking globally and holistically at the total cost of care. Or when you're setting targets for care you want to, or costs you want to contain, don't include the types of costs you want to encourage. Just look at restraining the kinds of care that are, sort of make sure the incentives are there for care to be directed toward primary
Is there another
limit.
Is there another way that we can say that they shall? And direct them that we really want them to be thinking about primary care I mean, we've said it in this bill how many times already that we want them to prioritize primary care, mental health care. Do we need to tell them this? I guess, I mean, that's a policy question. Leslie.
Well, I'm just back to that 6% of our healthcare spend is on primary care. And, I don't know how much includes mental health and substance use. Whereas 50% is in hospitals. So I'm thinking I want to see 20%. I mean, I want to see 10%, 12. Some people say 12, 15. So I think much more should go to primary care. How else does the board able to quantify what portion of total cost of care is coming to primary care? And that's what's important to me. And maybe this isn't the place, and I get that, but I just think that we need to know that.
Yeah, I hear you. I don't know if this gets us there.
Yeah, I get that.
I think the board has the broad authority to determine what's included in net patient revenue on their own already, and they could say the net patient revenue could be greater, including these kinds of services that we want to encourage. There's nothing discouraging about what the Green Mountain Care Board's doing when they're studying this net patient revenue. And if they could make any allowance they want already.
Do we know where this came from, number 7? Any?
I don't remember.
Yeah.
Did this come from?
Remember.
Yeah, it has that feel.
Yeah.
I don't remember. I mean, you could
Take it out.
take it out. You could put the focus on in different ways. You could have them, determine the amount of revenue derived from those categories if you're interested in having the board more aware of what the amount is. You could, going back to the consider, you could say, consider excluding revenue. You want them to consider, I mean, you could frame it in whatever ways you want.
I think
Or not.
if we, and Woody, I see you, but I think in my memory of where I think this came from, I think that certain hospitals have, when they talk about the budget orders and the revenue that they're allowed, that they have always used this, well, we really want to expand primary care, but we can't because then we'll have excess revenue.
Right.
So how do we get that to say that your excess revenue from expanding primary care, mental health care, substance use disorder treatment is not considered? So they can't come back and say, well, we were gonna, we were gonna double our primary care capacity, but you said we couldn't make any more money, so we had to cap it.
That's right.
Woody?
Or could they also, I'm just thinking out loud, could our hospitals also be losing money on some of these things such as mental health care? And then the other issue I had was urgent care centers also have to be included as well.
We don't regulate urgent care centers.
They're considered independent.
And even if they're affiliated with a hospital.
If they're affiliated with a hospital, they get reviewed as part of the hospitals in the same way that outpatient clinics get reviewed as part of a hospital.
So I guess I don't understand what we're trying to do.
I'm sorry, I didn't hear the last.
I guess I don't understand what we're trying to do here. Is it number 7?
We're trying to ensure that if a hospital wants to expand these services, instead of being afraid that they're gonna go over their cap in revenue, they instead restrict these services.
So should we have something in there saying that hospitals that do these three things, primary care, healthcare, and substance use disorder care, if they take in more money than they're supposed to, then they won't be penalized. Is that something that we should be putting in?
I think that's what we're trying to say.
I just jumped ahead to the thing from Green Mountain Care Board. I just looked up section 5, number 7, they cross out exclude and put consider revenue.
Yeah, that's what I had as well.
Everybody's got consider.
That's recommended by the Green Mountain Care Board.
I mean, if you look at that language, then it would say consider revenue from those derived from those sources when determining a hospital's net patient revenue and any total cost of care target. So maybe that does some version of what you're talking about.
Yeah, I think it does.
But the hospital shouldn't be penalized if they go over, and should that be included somewhere?
Or they shouldn't use the expansion of additional revenue from these services as a reason not to do them.
Not sure I followed that.
Well, it's just. I know that the CEO of the Health Network came in and was talking about how they had developed new efficiencies within primary care around scheduling. And they were able to open accessibility and see more patients, but they didn't want to do that because it was generating revenue, which then put them over their cap. I don't know how we do that. I think that's what this section was trying to get to. I keep calling it a section, but I know it's not.
This language.
It's this language. So if we use consider, will that do that?
I mean, it highlights the issue for them. It doesn't tell them what to do with it, but it's not,
Maybe we don't need to.
but yeah, but well, this is.
We went
Well,
Shall restructure the whole.
It's in a shell area.
Jen's grammatical thing got all.
But shall consider is pretty low level of, I mean, I'm not sure you need, consider is,
Any better?
yeah.
Might as well not, I'm
Do you want consider for the next draft?
Yeah, I think we should do consider.
What does that mean?
Shall consider? Think about it. Take it into your future.
Take it under advisement?
Take it under advisement.
Means nothing, right?
Shall be aware of, all right.
No, I think it brings their attention. It's like, okay, all these revenues coming from primary care, and last year it was like 5%, and this year it's 10%. And how cool is that?
I mean, you do tell them to consider various other things, so considering is not outside the realm of what
When I
they.
hear the word consider, it means consider it for what?
Be aware of.
All right, so we changed exclude to consider.
Yep.
Okay, in the next draft.
All right, lots of renumbering.
Numbers.
I don't know if you want me to go through what's being
No,
No.
renumbered.
No.
Okay.
no.
So then we're on page 12. And this is the piece I was reading from earlier about considering the salaries for the hospital's executive and clinical leadership. Could add including variable payments and incentive plans. And then the existing language around the salary spread and comparisons, and then adding a comparison of the base salaries and total compensation for the hospital's executive and clinic, and it should be clinical leadership, with those of the hospital's lowest paid employees who deliver healthcare services directly to hospital patients.
And the Green Mountain Care Board supported that.
And then consider the number of, this is the piece that we talked about before as well, the number of employees whose duties are primarily administrative compared with those primarily involved delivering healthcare services directly to patients. And in the earlier version of this, in the hospitals to report, you struck that. And if you want to strike this,
Green Mountain Care Board wanted it in statute.
they did want this.
I wrote down put in statute. Ask them for sure.
Well, I think first of all, it goes here more than it went before.
And Owen's here tomorrow, we could ask him.
Ask Owen tomorrow. Um,
And to distinguish, do we need to distinguish between administrative and administrative executive?
I actually kind of think it's important in the budget, hospital budget review process, and here's my only thinking. And Mari, you would know this, is that there's kind of general guidelines around efficiencies, hospital efficiencies, practice efficiencies, sort of the number of administration per provider, you know, support staff that is needed to support individual providers and individual services. And I think that's kind of what this is getting to.
And it would pull in, like, I'm thinking of coding, billing, health information technology.
And I realized it was the chart. I realized that it was the network, but if you remember when Chair Foster was here last time, he had all those lists of the various departments within the network. The name and the number of employees and the dollar amount in those departments. And I think at one point someone said, "What is that?" And he said, "We have no idea."
Yep, it was that blue piece of paper. Remember that?
And
Had the cut and paste of the emails, and he was like very frantically showing us this. And then there was the blue pieces of paper, and we're like, what is that? And he goes, I have no idea.
but I mean, think about in terms of if you have one hospital who has 100 providers and the same number of beds, and another hospital with this 100 providers and the same number of beds. What if one hospital has 400 people in billing and the other hospital has 50 in billing?
What's the story?
Yeah,
Well, remember the coding, and remember they had 76 positions for coding, not coding, PAs at UVM. And we were shocked.
76 open positions?
No, 76 filled positions in order to do PAs.
Prior authorization.
Yeah, sorry.
Physician assistant.
Sorry.
That's when I was confused.
which by the way, this is a great thing for all people to have. So, you know, we did that prior authorization bill. And the hospital we have 70 some people whose entire job is to do nothing but prior authorizations.
Put up roadblocks, yeah.
So I mean, I'm inclined to keep it in here in this section.
I'm good with that.
Okay.
Let's ask.
Yeah, but we'll ask tomorrow.
17 is what we were talking about.
Yep, 17.
Now that would also cover the highest level of administration, right?
16 has.
Oh, my bad, it's there, that's more specific.
That's
Sorry, you're right.
specific to executive and clinic leaders.
Okay.
Mari?
Just want to say I'm officially brain dead.
Yeah,
I am too.
I know.
There's only 5 minutes left.
we got 5 minutes.
4 minutes.
Well, I think the question is, do you want to, because now we move on to the subsection C, the individual hospital budgets. Is this a better place to pick up tomorrow?
Okay, maybe this is something to pick up tomorrow.
Then we're keeping 17.
We'll be in better shape if we just
Yeah.
acknowledge our limitations as humans.
Okay, in all honesty, we got through a lot more than I thought we would get through today.
We're almost halfway.
So thank you.
Yes.
Thank you, everybody. Okay,